Hello, everyone. Thank you for coming. Welcome to NATO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NATO's Executive Director. Norm, the stage is yours.
Well, thank you, Erica. It's a real pleasure to be with you again for this session. We're looking forward to having a discussion today about using health data analytics to address health outcomes. This session is sponsored by Chariot Solutions, and we'd like to give Tracy just a minute to introduce Chariot Solutions.
Hi, my name is Tracy Wilson-Rossman, and I am Chief Marketing Officer at Chariot Solutions. We are a Philadelphia-based software consulting firm that's been in business over the last 20 years. We've seen so many changes during this time period of how software development has included not only connections, regular software development, but also connections to the capture of data as it relates in the cloud, as it relates to legacy systems, and getting that data to be put correctly so that it can be used in the best way possible by the data analysts, by product managers, by data scientists. It's really important to have that data in the best shape possible. So please feel free to contact us at chariotsolutions.com, and we look forward to sponsoring this session.
Thank you, Tracy. It's now my privilege to introduce our organizer and moderator, Nicole Fawcett from VHI. So Nicole, welcome to the stage. How are you today?
Thanks, Norm. Good. How are you?
Great. All right, take it away.
Good. Thank you so much. Hello, everybody. Thank you so much for joining this session. So as the session title reveals, we're going to be hearing 3 great presentations today that all demonstrate examples of how data analytics can be used to address outcomes. So, of course, this is a topic that's quite broad, but is also important and relevant in a variety of ways. So each of our presenters are going to be bringing different perspectives as to how this can be accomplished. And so we're excited to hear from them. So I'll introduce first up, we have Nate Pauley and Adam Stryer from Manat Health Strategies, and they're going to be sharing their analysis on exploring system failures, investigating disparities in payments for healthcare providers serving historically marginalized populations. And so they're going to be walking us through how they used APCD data to support this work. So I'll turn it over to them.
Hello, everyone. Thank you for joining us today. My name is Adam Stryer. I am a senior manager with Manat Health, and I am joined today by my colleague, Nate Pauley, also a senior manager with Manat Health. And we are here today to share with you some detail on our research project that looks into the question of whether healthcare providers who serve historically marginalized populations are paid less. So this work is based on a research report that we have been working on with the support of Arnold Ventures. This report will be available to the public within the coming weeks. So to the extent this is of interest to you, we encourage you all to go ahead and check out that report. So I'll just start off by providing a little bit of background. Just to say, we will be using the term historically marginalized populations, or HMPs, throughout this presentation. Just to note that this includes Black, Hispanic, American Indian, Alaska Native, and Native Hawaiian and other Pacific Islander individuals. And we are really just using this term to simplify the analysis that we are doing. So I think everyone on this webinar is well aware that HMPs experience a range of disparities in healthcare outcomes and in access to care. HMPs generally suffer from lower life expectancy, fare worse on measures of maternal and infant health, and have higher rates of a broad range of chronic conditions. One thing that is clear in the existing research is that this is partly driven by unequal access to care. HMPs are more likely to report not having a regular doctor, or more likely to seek routine care from the emergency department, etc. The list goes on. So what is to blame for these access disparities? The existing research, that there are a broad range of factors that contributed to unequal access, but the research really suggests that one significant contributor is insufficient reimbursement. We know that patients who have lower reimbursing insurance tend to receive worse care and have worse health outcomes. We know that less financially stable hospitals are less able to make critical investments in things like staff and equipment. We also know that there has been a spate of hospital closures among safety net facilities and rural hospitals, which are those that tend to be less well reimbursed. And that can have really significant implications for outcomes for people who are served by those institutions. So we sought to investigate whether this issue of low reimbursement is uniquely experienced by providers that disproportionately serve HMPs. And this can really manifest in two ways. One is through payer mix. We know that Medicaid payers in particular tend to pay less than Medicare, which tends to pay less than commercial. And we also know that HMPs are disproportionately represented within the Medicaid program. So just by that alone, providers that disproportionately serve HMPs are sort of inherently disadvantaged financially by their payer mix. But we also know that there is considerable variation in payment rates within payer categories. And this is particularly prevalent amongst commercial payers. There's considerable evidence that commercial payers pay providers at very different rates, even for the same services. So what we sought to investigate through this analysis is really whether this issue is uniquely experienced by providers that disproportionately serve HMPs, and specifically whether those providers receive lower payment rates on average. So I'm going to turn it over to Nate, who's going to say a little bit about our methodology and preview some of the key results from this report.
Thanks so much, Adam. So we sought out to work with partner states in Arkansas, Massachusetts, and Virginia to examine whether hospitals that disproportionately serve HMPs are paid less across payers relative to other facilities. We used two different types of data sources for this analysis, including both all payer claims data, or APCDs, and hospital discharge data. We used APCDs to calculate the average hospital payment rate for a select basket of services stratified by payer type. We then used hospital discharge data to characterize the percent of admissions attributable to historically marginalized patients at each facility in a given state. We used hospital discharge data to characterize the race and ethnicity of hospital patient populations because we know this information is frequently missing or inaccurate in all payer claims data. After analyzing our APCD data and our hospital discharge data, we then linked results from these two analyses at the facility level to examine whether hospitals that disproportionately serve HMPs are paid less across payers relative to other facilities. We worked with our partner states to develop a standardized analytic approach that could be consistently operationalized in all 3 states while accounting for state-specific data limitations. Just to give you a sense of our overarching analytic approach, our analysis included all paid outpatient hospital claims with CPT procedure codes corresponding to services in our basket of services in calendar year 2019. Our analysis primarily focused on commercial and Medicare Advantage payers and included records from all commercial and Medicare Advantage payers that were included in each state's APCD. All of our analyses and results were stratified by state. For the purposes of this analysis, we characterized HMPs as patients who were classified in hospital discharge data as having either Hispanic ethnicity or non-white race. We worked with our state partners to identify a basket of 11 common outpatient services that included things like appendectomies, chest x-rays, and CT scans. We identified these services as our services of interest based on data availability, coding practices, and comparability across payers and states, and generally sought to develop a basket of services that were commonly rendered in the outpatient setting. To give you a sense of how we examined associations between payment rates and HMP patient populations, we ended up calculating what we called a weighted average payment index at the hospital payer type level that indicated whether a hospital was paid more or less on average by a given payer type across all services of interest in our basket of services. We then compared the weighted average payment index for each payer type for hospitals that disproportionately served HMPs relative to other hospitals in the state. For this analysis, we characterized hospitals that disproportionately served HMPs as those facilities that were in the top decile in terms of the proportion of HMP patients represented in their hospital discharge data. We then calculated what we called a payer rate ratio, which we calculated by dividing the average weighted payment index for hospitals disproportionately serving HMPs by the average weighted payment index for all other hospitals in a given state. This table down here at the bottom of the slide gives you a sense for how we calculated the payer rate ratio for commercial and Medicare Advantage payers in Arkansas. Now, we're not going to have time to go through all of our results in detail, but this table gives you a high-level overview of some of our key findings in each state. We found consistent trends in all 3 states that commercial payers paid more on average for services in our basket of services relative to Medicaid payers. We also found in all 3 states that Medicare Advantage payers generally paid less than commercial payers, but more than Medicaid payers on average. We found consistent trends that hospitals that had a higher proportion of Medicaid patients also tended to have a higher proportion of non-white patients. And we found evidence in all 3 states that hospitals that had a higher proportion of Medicaid patients were paid less on average overall relative to other facilities, driven by lower Medicaid payment rates relative to Medicare Advantage and commercial payers. And finally, our ultimate finding, we found evidence in both Massachusetts and Arkansas that hospitals that disproportionately served HMPs were paid less on average from both commercial and Medicare Advantage payers relative to other facilities in these states. This figure gives you a little bit more detail on our results comparing payment rates for hospitals disproportionately serving HMPs versus other hospitals. To give you a sense for how to interpret these results, we found that in Arkansas, hospitals disproportionately serving HMPs received 7% lower payment rates from commercial payers on average for similar services relative to other facilities in the state. In Massachusetts, we found hospitals disproportionately serving HMPs received 15% lower payment rates from commercial payers. And again, in Virginia, we did not observe substantial differences in payment rates for hospitals disproportionately serving HMPs. Now I'm going to turn it back over to Adam to give a quick overview of some policy levers that states can consider to address these disparities.
Great, thank you, Nate. And I will just very briefly go through some of the policy options that we highlight in more detail in our paper. So in terms of interventions that would that states can take outside of the commercial market, states can raise Medicaid payment rates. They can increase the transparency requirements with respects to provider payment rates. They can target investments to providers that serve HMPs. They can also implement various incentive programs for public and private health plans to help get at this issue. And then within the commercial market, states can also establish state cost growth benchmarking programs that account for equity considerations. They can account for equitable payment rates when doing their insurance rate reviews. And states also have the ability to implement all payer rate setting type programs. Great, so that's all that we have for you today. And we are happy to discuss this further through the Q&A and answer any questions that you may have. Thank you all so much.
Great, thank you so much for that presentation. That was awesome. I want to echo Adam's last comment and just encourage folks to put their questions in the chat in the Q&A tab, and I will be happy to field those. That would be really great to be able to hear from you all so that we can guide the Q&A portion accordingly. I did want to ask, before I get to my own question, we do have a question in the chat that I'll address. Cindy asks, any thoughts on how pay-for-performance policies can impact these disparities, especially in the Medicaid space?
Yeah, I can take a pass at answering this. I'm not sure I'll have a satisfactory answer because I don't know that we've necessarily seen pay for performance policies in Medicaid that are specifically targeting the commercial payment disparity issue. I think it can certainly, it could have a positive impact within the Medicaid space for sure. And we know, based on the data that we showed, where HMPs are really disproportionately represented in the Medicaid program. So, to the extent that states are flowing additional dollars to sort of inherently benefits providers that are serving HMPs. But I think, it certainly would be interesting to think about as well, mechanisms where states can leverage Medicaid pay for performance to try to make strides within the commercial market. I don't have a great answer on what that would look like at this time, but I think it's something that's certainly worth exploring.
Great. Yeah, thanks for sharing your thoughts on that, Adam. I was going to ask you all, and if anything else pops up in the Q&A, I'm happy to kind of go to that. But I wanted to ask, can you all speak to your experience of like utilizing hospital discharge data in conjunction with APCD data? I would just imagine that a lot of our audience members probably have access to both sources, like in their respective states maybe, but as we all know, linkage just tends to be like nuanced and challenging. So I know that's kind of a loaded question, but if you have any high level thoughts on how you feel like that process went and what the challenges may have been with that.
Yeah, I'm happy to tackle that one. So again, we used the hospital discharge data primarily to characterize the race and ethnicity of the hospital patient populations, and really used hospital discharge data for that because we know that information on patient race and ethnicity is often missing or potentially miscoded in administrative claims data. So I think that one of the big challenges here is being able to link the hospital discharge data to the administrative claims data. We were very fortunate. We had to gloss over this in the presentation, but we were fortunate that we had our health data partners in Virginia and Massachusetts and Arkansas who were able to do that for us, and actually had facility IDs in both data sources that they could use to link the results from the hospital discharge data to the results from the APCD data. Would say that another challenge in terms of characterizing the patient race and ethnicity, though, is just determining what the right categories are. So you'll notice that we characterized any individual who is non-white as being a historically marginalized population, and recognize that definitely glosses over a lot of the nuance in terms of these different categories. I think those are the main things that I would highlight.
Yeah, no, that's great. That's really helpful feedback. Thank you, Nate. Okay, last quick question I'll ask. And again, anybody in the audience, if you want to put your questions in the Q&A, I'd be happy to pass them along and facilitate that. I wanted to ask how challenging, or maybe not, it was agreeing upon like which services would be included in the basket. Like, do you feel like that kind of fell together and seemed obvious once you ran those preliminary analyses, or was there a bit more of a back and forth with that as you convened those partners to decide what the basket of services would entail?
Yeah, I can speak to that too. It was definitely not an easy process. There was a lot of back and forth. The basket originally started out with a lot more types of services in the basket. Ultimately landed on the ones that we did because they were services where we could see that they were consistently used across all three of our states, and were services that were pretty consistently used by both commercial and Medicare Advantage patients. Another challenge that we had initially we were considering whether or not we were just going to focus on outpatient services or inpatient services, and went through a lot of different iterations initially where we were using different approaches for looking at costs associated with inpatient services, but ultimately carved inpatient services out of the analysis just due to variation with how those services were billed and how payments were recorded in the different state data systems. So definitely a lot of thought that went into that. And we'll say that we did look to some previous analyses that have done sort of market basket type analyses like this to get a sense initially for where to start in terms of the types of services that we were looking at. But definitely spent a long time refining that list with our state partners.
Yeah, I would imagine. Great. Well, thank you all so much. I'm sure there will be additional questions that may come up in the chat toward the end of our session here, but great hearing. I mean, I'm from Virginia, so I'm biased that it's like obviously very enjoyable for me to see how the data is being used and how it can be transformed by these analytics to have it be powerful and impact policy and other changes downstream. So thank you all so much. I'm going to pivot. Next, we'll be hearing from Mike O'Neill from Medicasoft. And we'll be hearing from Mike on the topic of investment return through practical data analytics. So I will pass it off to Mike. So Mike, take it away.
I'm going to spend a few minutes talking about how we can make investments in our data analytics solutions in a pretty rapidly evolving environment and feel that we have some level of comfort that we're maintaining a return on those investments. But let's first start by looking at our overall big picture here. Healthcare, we've become and are becoming increasingly data-driven. I think people like us here think that's generally a good thing. We've been working to help improve outcomes. This is increasingly something that requires access to more data, more types of data. We're moving beyond things like care coordination or identifying gaps in care to addressing health equity, access to care, building a bigger, broader picture of individual patients and patient cohorts, incorporating things like social determinants of health data, behavioral health, and so forth. There's always a focus on increasing efficiency, so we'll always be looking at assessing the cost of care. But I think we're getting into maybe a higher order looks at efficiency where we can recommend improvements to workflows, both clinical and administrative, things like prior authorization and so forth. And of course, many of us are involved with using our data to support the research community, and this is something that has an ongoing appetite for more data, types of data, being able to link different data sets to the same patient. If we think about this as kind of a big picture, almost economic equation, on the demand side, we've definitely got an increased appetite. On the supply side, there are some things going on that help us make more data accessible. The standards community has always worked on how we represent, how we manage claims data, clinical data. Things like HL7 FHIR have gone a long way in recent years to making data more easier to work with and to exchange. And the standards community has looked more at not just how we represent or model data, but how we can share it, exchange it, how we make it interoperable. The government and the regulatory environment, I think we can generally say has helped in this area. There's been a push for more than a decade now to make more data electronic, make it more available, going back to meaningful use in the EHR community, all the way through things like the CMS interoperability rule. And the technology community marches on. So things like cloud architecture, technology for data warehouse, data lake, big data analytics, these kind of technologies make it easier for us to aggregate really large amounts of data and then work with it efficiently. So it sounds overall like a good story. If we have some increasing demand and we've got some positive trends on the supply side, sounds like this looks great. I think when you dig into it, we are talking about not just adding more data, but more types of data, and this brings its own set of challenges. There's just a complexity with managing multiple data sources, so many different data sources, including sources that maybe aren't used to the healthcare system, the healthcare IT infrastructure. The standards that I mentioned definitely continue to evolve, but they have to keep up with handling types of data that maybe we haven't in the past. We are getting into types of data that are considered sensitive and types of data that require patient consent. That's the other side of building out a data picture that's more comprehensive on a patient. We have to engage the patient and consent to a greater degree. And the legislative regulatory environment, that will continue to evolve. I'm thinking about living in a world where there's legislation around what you can or can't share with things like reproductive data. So if we were to take kind of this environment and start to boil it down to what are the technology implications that drive investment for us, I think we're looking at a picture where we've got to maintain our flexibility. What it means to be claims data is going to continue to evolve, and we're going to need to incorporate not just clinical and EHR data, but other types of data that we would probably consider non-traditional in the work that we've been doing. We're going to need to be able to manage patient identities and link data sets. We're going to need to be able to have an infrastructure that keeps track of sensitive data, that keeps track of patient preferences for consent, and make sure that the right data is used in the right applications, the right use cases, and given access to the right people, and not to any of the use cases or people that are not entitled to see it. We also are going to be dealing with, I think, a stakeholder community that continues to have the traditional folks who are really comfortable working with data, who are data experts, but increasingly will be working with people who are not, who really need the information, but don't have the expertise maybe to dive into the data. And that has an implication in the investments we make in tools and how we present that information to them. So in that environment, there are some things that I think we can do if we take a step back and look at the enterprise architecture level across our entire enterprise, where some investment up front, some consideration up front pays dividends as we evolve our solutions. And the first thing that I've mentioned here is actually the data model. And yes, it dives down into some of the technical weeds, but the more flexibility that we have to choose a data model and maintain it over the years, the more we make our investments on how to get data into our systems and then how to make that data usable, we can really optimize those investments. If every time we need to deal with a new type of data or we need to support a new use case, we need to go in and choose a new data model or expand a data model, that really drives a lot of investment that is hard to leverage and hard to reuse. So selecting a data model, as boring as it may sound, is one that pays dividends. We also should, I think, look at, linked to the data model picture, is what is the framework where we identify data that is sensitive, and the framework that we identify and manage what are the patient preferences for sharing that data. A consent model is something that's worth putting some investment into. And then we should look at how we are set up to provide access to the stakeholder communities, as I mentioned. I think for many of us, our starting point is something in the all-payer claims database universe that looks roughly like this, a pipeline that manages claims data and ends up putting it into some type of data warehouse. And of course, this is a great architecture. It's served us well for years. But as we move to supporting more data and the types that I've mentioned and some of the policy and governance considerations around that, I think taking a look at a platform level is something that pays dividends from an investment point of view. A structure, an architecture here that isn't tied to any one particular technology, but allows us to group together the services that we use that import or bring data into our environment, that can do that in a flexible way. That's a good point to consider in the architecture. To have a centralized data model that represents data in a common repository. Here you can see we've focused on HL7 Fire as the representative data model. Maintaining a central repository that aggregates patient records when we are driving use cases that are involved in treatment, care coordination, and so forth, outcomes related applications. Those are well served by this type of data repository. And then an architecture that puts data in an optimal form for analytics, for reporting, probably for many of us increasingly for machine learning and for AI. This kind of a platform architecture allows you to keep reusing the framework as your needs evolve without having to throw away any of the pieces, and giving you flexibility to change technologies as needed. The last thing I'll say here is it's really worth taking a step back and making sure we make practical considerations as we make our investments here in data analytics. First is to recognize that an iterative approach is going to be the way to go here. It's not really likely that we will be able to step back and say, well, when everything is resolved from technology questions to policy, then I'll implement one solution and one solution only. Actually, what that can end up doing is causing us to freeze, to not move forward in any investment and miss opportunities to actually serve our stakeholders. So if we are able to start small and take an iterative approach, we still want to make those architecture decisions that I mentioned. Those can endure through the iterations that we take. Try to limit dependencies on individual point technologies, avoid siloed solutions, and so on. And the last thing is, as we iterate, as we make these investments, give the priority to real use cases that have stakeholders who are actually ready today to take advantage of the data that we can give them access to. I think this type of an approach lets us make investments with confidence that we'll get a return and that we won't have to throw away an investment each time we tackle a new problem.
Great. Well, thank you so much, Mike. So much to dive into with all that great content that you shared. I'm going to go to the Q&A because we already have some questions in there from Helen. The first of which is, with all the regulations and the legislation that's coming out or in the works, how can we make sure that we handle sensitive data properly?
Yeah, it's really an important one. As you know, we have a lot of drivers that are moving all of us to gathering more data. We heard from our previous presentation trying to further quantify different patient cohorts and so forth. As all of that happens, what happens when we build a better, let's say, a broader picture of individual patients, and we get into areas of their care or their treatment or their demographics that need to be protected, either because they just don't want us to share it or the government tells us we can't. So what we try to do here is make sure that your IT investments, your architecture, is in service to those ends, not puts restrictions on you. So what does that mean? I mean, I know in the presentation we said data model multiple times, but one of the aspects of a data model is, does it make it easy, not just for you to store data in a database? And anybody can do that. But can I store that data with enough information, let's say metadata, about it? This is considered sensitive, or this is not, or on a granular level or a broad level. Then I can rest assured that as the environment changes, laws get passed, regulations come to place, my data is still usable. I have metadata associated with it that tells me how it needs to be handled, and then I can use it with confidence that I'm not violating a patient trust or violating a regulation or a law. So a lot of it turns out to be how do I make sure I can tag or somehow identify data so that I can give some meta information about it, including whether it's sensitive or not.
Thanks for that response. Yeah, that's really helpful. And I'm sure that a lot of folks in the audience are, though I'm sure the wheels are turning for them with their own data sources, as they are for me personally as well.
Especially in states where legislation like this is coming out.
Absolutely. And I have a follow-up question from Helen as well, which I'm also curious about. She asks, as we add more types of data, how can we make sure that we link the right data to the right patient? I know this is an age-old question, and it's a big one to tackle, but what are your thoughts on that?
Yeah, and actually, again, I think in our previous presentation, we heard about linkages, linking data. It's typically like within a healthcare system or a payer system, we have an identifier that we can rely on. But the more we get data from more sources, the less you can count on being able to use just pure identifiers. So a solution that I would say on the clinical side that most healthcare systems use is master patient index. I think when we deal with claims data, pure claims data, we often don't need or don't feel that we need an MPI. It's getting to where an MPI is more and more helpful. Many of you are probably more experts on MPIs than I am, but if you're not, it's essentially a way to say, I'm going to manage like a master identifier for this patient. Then however I hear about or get data for that patient, I have a way to say, hey, for this name and date of birth and address, tell me, do you know this patient? What is the identifier? That kind of a thing. It's a great technique to be able to link disparate data sets. I think the thing that we have to keep in mind is it's not as simple as let me buy an MPI. Actually, the process of managing identities, the MPI is a great tool and does all of the algorithmic, how do I know that the demographics you gave me for patient A and patient B are the same? That's great. But managing those identities over time is a process. And you can actually, especially I would say at state levels, let's say if you have a state HIE, for example, Health Information Exchange, that has been doing this over the years, they will have accumulated, let's say, like curated patient identities. And if, let's say, you have Medicaid data that you want to start to take advantage of there's organizational and contractual and all kinds of things that have to be factored in. But from a pure technology point of view, it's great to be able to take advantage of a curated set of identities and keep reusing that and expanding on it versus buying an MPI and starting over from scratch.
Yeah, absolutely. Thanks. That was a really great and helpful answer. I'm sure there's a variety of audience participants or members who are familiar with the Master Patient Index, or maybe they're hearing about that for the first time here. So thank you for bringing that up. I did want to ask one additional question of you. I know you mentioned some of those like non-traditional data types in your presentation in terms of kind of bolstering analytical flexibility down the line. Can you give examples of what some of those non-traditional types of data might be for folks to consider?
Sure, yeah. And I realize after saying something like non-traditional, it's all relative. For some folks, what I'm going to say, look, I deal with that every day. For others, it's totally new. But if we think about often the picture that we're building of a patient is based on claims data for many of us. Maybe if we are getting EHR and clinical data, that's great. Non-traditional, if that's your frame of reference, non-traditional can be things like employment data, educational data, data about whether you have received or are eligible for community services. This can include things that sometimes we may not think of. Food bank, for example, if we are looking at a patient's overall wellness and their nutritional status, sometimes whether they have been accessing food bank is part of building that picture. If we turn it around and look at if we are able to gather these types of, let's say, non-traditional data, the things that people are trying to do with that is, in an analytics framework, is to say, look, if I can maybe move from telling that a person has a condition already and have they been treated and what was the outcome to what could I do to improve their overall wellness, and should I introduce the idea of community services to them if I think it could help. You can't really do that if you're not able to incorporate those sources of data into your model.
Yeah, absolutely. Absolutely. Those were great examples. Thank you so much. I want to encourage folks in the audience to drop any additional questions for Mike in the Q&A tab in the chat. And if we didn't get to it now and you still have a question for him, we may have some time at the end to where we can still have him answer. So thank you so much, Mike, for that comprehensive overview. I'm sure a lot of folks in the audience and even our previous speakers, like you alluded to, can relate to those use cases and enablers and challenges that you touched on. And I think that the architecture piece there for longevity and flexibility, like you emphasized, is really important. And it's what we all need as this is such a rapidly changing environment for all of us. So thank you so much for bringing that knowledge to us. And so for our third presenter on this topic is Hannah Murphy. And Hannah is joining us from the Center of Advanced Analytics and Informatics at Vizient. And Hannah will be talking us through an analysis addressing patient characteristics among pregnancies across the COVID-19 pandemic to present using administrative claims data from the Vizient the Vizient clinical database. So I will turn it over to Hannah to walk us through that.
Hi, everyone. Thanks so much for having me today. My name is Hannah Murphy, and like a few of the other folks that we've heard from, I'm also with Vizient in the Research Analytics group. I'm excited to present today about how I utilize the Vizient clinical database to examine patient characteristics among pregnancies over the last few years. And so with that, let's get started. Here's an overview of what I'll be discussing today. I'll start with a project-specific overview. I'm going to give you some background and context for how this study fits in with current literature. I'll also discuss methods and end with some final results and a discussion and some talk about what's next. As we've heard about from others, the theme of this year's conference is building a bridge between data and policy. There's an abundance of data sources, and mechanisms to go about this translation between clinical work and policy. In my project, I'm utilizing administrative claims data to derive insights on trends relating to pregnancies over the last few years and inform the healthcare continuum between researchers, policymakers, clinicians, and patients. This fits nicely in with the theme of our group for this section, which is using data analytics to address outcomes. Now, moving into a topic that has piqued a lot of research interest in the last few years, looking at pregnancy-specific data analytics. Severe maternal morbidity, or SMM, was defined by the CDC as a pregnancy complication that causes significant adverse outcomes for the pregnant person or puts them at risk of death. There are 21 indicators, including, but not limited to, aneurysm, acute renal failure, eclampsia, shock, and then others. These all leverage ICD-10 diagnosis codes to identify hospital deliveries with SMM. In the past few decades in the United States, SMM rates have increased nearly 200%. The figure to the right shows work that was completed by Fink and colleagues quite recently, where they show SMM rates per 10,000 hospital discharges through 2021. Notably, we see dramatic rises in the unadjusted SMM beginning in 2020. In addition to these dramatic rises, as shown in the bottom figure here, rates of maternal mortality in the United States are among the highest among similarly developed countries. Studies have shown repeatedly that SMM disproportionately affects vulnerable populations, for example, those among racial and ethnic minorities and zip codes with low socioeconomic status. Consequences of SMM are numerous. Throughout the healthcare continuum, this includes higher costs, longer hospitalizations, and overall worse outcomes. Specific to the COVID pandemic, there have been plenty of studies, there have been plenty of anecdotal reports and clinical observations reporting COVID-related impacts on pregnancy and perinatal outcomes. COVID infection itself has been shown to increase the risk of adverse pregnancy outcomes, like stillbirth and premature birth, particularly when exposed in early pregnancy. Secondly, changes in healthcare practice, policies, and programs have had impacts on pregnancy-related outcomes, such as changes in policy related to the labor itself, like reduced support persons, and the need for early discharge to reduce infection risk. These changes in policy, procedure, and risk highlight the need for longitudinal studies using recent data across the COVID pandemic timeline to examine adverse complications and outcomes, particularly among those most impacted by these recent changes. The objective of this specific study was to utilize health data analytics, specifically as longitudinal administrative claims data, to examine patient-level characteristics of those with pregnancies resulting in live births, recent time trends of SMM, comorbid pregnancy conditions, and relevant perinatal outcomes. This study utilizes an exceptionally large clinical database that represents over 97% of academic medical centers, with over 1,350 Vizient member hospitals contributing data. We are able to examine trends pre-COVID and recent trends up through 2022, allowing for us to look at the changing landscape over time as the world drastically changed. Due to the expansive nature of the dataset, we are also able to examine a multitude of perinatal outcomes and risk factors. We know that nothing happens in a silo, especially during pregnancy, and examining these factors together allows for a more complete picture. Using the Vizient clinical database, we identified a retrospective cohort of over 4.1 million pregnancies using administrative claims among persons aged 12 to 55. These pregnancies were limited then to those who resulted in live births between January 2019 and December 2022. You can see at the figure in the right that these 4 million pregnancies were pretty well evenly distributed across the study period by year. Encounters were then flagged for indices of severe maternal morbidity, leveraging the logic from the CDC. They were also flagged for relevant pregnancy-specific complications, which I will get into a little bit further, and notable pregnancy outcomes. Among this retrospective cohort, on average, patients were 30 years of age at admission with a standard deviation of about 6 years. They were largely white or Black, and 20% were Hispanic. The majority had a commercial or private payer, about 53%, closely followed by Medicaid at 41%. And then looking here at the bottom right-hand side, we see a varied distribution with the most folks in the South, followed by the Midwest. Utilizing CDC-identified SMM indices, patients were stratified to those with any SMM indicator versus none, and overall 2.2% had any SMM indicator. The top 5 most prevalent indices are shown here as blood transfusion, acute renal failure, disseminated intravascular coagulation, acute respiratory distress syndrome, and sepsis. These values, they seem quite low, but they're generally in line with what we see for severe pregnancy complications nationally. Consistent with other literature, we secondly examined those with any SMM indicator, but now excluding blood transfusions. Now, 1.3% had any SMM indicator, excluding blood transfusions. We also saw significant regional differences within this sample. The lowest prevalence of patients admitted to the hospitals with SMM indicators were in the Midwest, compared to, in the following increasing order, the Northeast, South, and West, despite the majority of patients coming from the South and the Midwest. Next, we examined differences across years given the changing healthcare landscape due to the COVID pandemic, and these trends revealed significant changes in maternal morbidity over time. One-way ANOVAs followed by post-hoc Tukey's tests to examine where in time differences existed, highlighted increases in prevalence of SMM indicators over time, also found when excluding blood transfusions. This is all to say that in addition to the nearly 200% increase in SMM over the last 2 decades, the prevalence of SMM is continuing to rise further. This recent data points to trends that are likely exacerbated by the COVID pandemic and only continuing to get worse over time. Now moving on to some outcomes. Using 2 sample t-tests, patients with any SMM indication were found to have statistically significantly longer total length of stay and total days in the ICU. The rest of the table here shows a host of complications and pregnancy and perinatal outcomes that are ordered by frequency, and all were identified using ICD-10 diagnosis codes found in the administrative claims at the time of delivery. Just about every condition was higher in those with any SMM indication, with the exception of premature rupture of membranes, which was both most common in frequency and not statistically significantly different between populations. It's worth note that these conditions were not included in the CDC's list of 21 SMM indicators, and all of these findings were replicated when excluding blood transfusion from SMM indication. From the last slide, we saw that trends of SMM are only increasing over time from their already increased states. And from this slide, what we see is those with SMM are uniquely impacted by adverse pregnancy complications and outcomes. There's so much room for improvement in our societal and healthcare of pregnant people and their related conditions, but reports on recent data and recent trend data are needed to communicate that. I now want to highlight a few of strengths and limitations to this study. As I've already mentioned, the Vizient clinical database is an increasingly large database, and for this study specifically, we had 783 continuously reporting hospitals providing data from all regions of the United States. The large sample size, validated diagnosis codes, and SMM indications allow us to examine these quite low frequency outcomes and their prevalence within the clinical database itself. We also have multiple primary payer types, a relatively diverse sample set, although that leads me to my limitations as well. Currently, the clinical database is predominantly comprised of academic medical centers, generally set in urban locations. Although we are gaining representation from community hospitals and other settings by the day, this still leads to an unknown generalizability into more rural settings. We do know that rural settings tend to have worse pregnancy complications and outcomes, so these findings are likely to underestimate the prevalence of SMM trends. Due to the nature of administrative claims, we rely largely on the index encounter and therefore have limited follow-up ability, especially if these patients are seen at other hospitals. Clear conclusions from this study were that 2.2% of all pregnancies resulting in live births within the clinical database had indications for severe maternal morbidity, and these trends only increased over time in the study period, notably so following 2020. SMM itself was associated with many adverse pregnancy complications and outcomes, and the risk factors for SMM indication should be considered in quality of care and other related improvement programs targeting pregnancy and maternal care, with a particular focus on those vulnerable populations that are most affected. Other outcomes, in addition to live births, should also be considered. While there's a lot of room for improvement in the healthcare setting, especially when considering pregnancy-related care, healthcare data analytics is a crucial way to address outcomes and bridge the gap between data and policy. And with that, I'd like to thank you all so much for your time. I'm happy to answer any questions, and feel free to reach out to me. My email is here if you have any questions regarding the Vizient clinical database. Thanks.
Great. Thank you so much, Hannah. Such a fascinating study that you were able to work on. I love seeing how claims data can inform so many different focus areas, and we all know the importance and emphasis on maternal health that's going on. So I want to jump to a question in the Q&A asking if you can use data to show the relationship between COVID infection and adverse pregnancy outcomes. Can you speak to that a little bit and how the data might be used to sort of parallel those two or demonstrate the relationship?
Yeah, absolutely. I think that's a really good question, an important question, and I think going to get more important as we move forward. So yes, you absolutely can use the data to look at COVID infection as it relates to pregnancy outcomes. There are some limitations I can kind of think about right off the bat. So this data specifically is hospital discharges and line item patient level claims data. And so the one tough part you're going to have is, it would need to come up in that discharge. So the COVID infection would need to be at the time, or would need to be documented at the time of the discharge or at the time of the admission. So, you're likely going to see only those who came in for really severe infection. You're probably going to be very underestimating those, mild COVID infections that still impact, especially early pregnancy. So you can definitely look at the severe COVID infections and how they impact pregnancies using discharge data. And I think it's a really, really important question. And I know there's been some kind of recent work on it. There's some lag time with just the lag of getting all of the data, but you absolutely can use the data for that.
Great, thank you. And again, just want to encourage any additional questions for Hannah to be put in the Q&A tab of the chat. Be happy to read those out so that we can all hear more from her. Hannah, I'm interested in the increase of the SMM trends, even following the height of the pandemic, like into 2022. For your analysis slides, were there any key findings or like assumptions maybe that you and your team made as to why those trends aren't really leveling out even now as we've kind of passed the quote unquote height of the COVID-19 pandemic?
Yeah, I don't know if I'm going to have, a really satisfactory answer on that. I think there's a lot to it. I think a little bit about what Nate and Adam spoke about reluctance to care as for certain populations may have something to do with it. I mean, SMM has been notably linked to prenatal care usage and utilization of prenatal care. Finding those early complications, finding those early health issues is really, really important and only lead to further exacerbation. So, I don't personally know the reason it's increasing. I think people are probably more reluctant to go to the hospital. They're more reluctant to, and hopefully that's changing. They're more reluctant to see a doctor. They're more reluctant to be around sick people, especially if they're pregnant. So I think there's a lot of kind of policy level issues, payment level issues, societal issues, a lot of things to address, a lot of social determinants of health to address to kind of level that out and hopefully meet some of our, similarly developed countries.
Yeah, no, absolutely. I know it was a loaded question, so thank you.
It's a really good question nonetheless.
So I want to go back to the chat because we've gotten a few additional questions for you. The first is, can you just confirm that your data was limited to the index hospitalization, limiting the link between prenatal care and the actual outcomes?
Yeah, that's correct. So in this, I simply looked at the discharge data for labor and delivery itself, and then kind of the charges or the diagnosis codes for those severe maternal morbidity indices. That would be super interesting to dive into, is looking at the link between prenatal care. If they happen in other settings, it can make it tough to connect the data. But there's a lot of people working on it, and I think it'd be really interesting for sure.
Absolutely. Thank you. And then Mark asks, did you stratify the SMM population on other comorbidities such as obesity, diabetes, hypertension, substance abuse, et cetera, to see if there's a correlation there?
Yeah, so I mean, I didn't personally. Inevitably, there is going to be. So some of those, for example, hypertension is included in some of those severe maternal or hypotension is included in some of those indices. But no, I didn't stratify based on that. I do think there's going to be some collinearity there between, some of those, especially like diabetes, specifically like gestational diabetes, gestational hypertension. A lot of those are going to be collinear with some of the outcomes. But no, I think that'd be really interesting, and I think it's great to not, like I said, none of that happens in a silo, and so looking at all sorts of factors would be really interesting.
Sure, yeah, absolutely. Well, thank you all so much. These have been such informative presentations, really covering such a wide scope and array on this topic. I kind of have additional questions for each of you. I know we have about 5 minutes left to get through them, but I'll just kind of work backwards. Hannah, one additional question for you. Can you dive deeper into some options or recommendations for making some of these much needed changes and improvements in maternal health? I know you gave some examples earlier, so if you could just reiterate some of those for the folks listening.
Yeah, absolutely. I think at a very high level, addressing the social determinants of health, addressing structural racism are kind of like the very high level of things that will impact down the line. But one of the biggest ones that comes to mind is integration of multidisciplinary care into prenatal care. There's such a focus on the pregnancy itself. It'd be great to integrate, primary care or other types of care into that setting, both before and after pregnancy. I think there's got to be a lot of programmatic changes, policy changes, clinical changes that result in really these widespread changes. But I think multidisciplinary care and encouraging prenatal care utilization are two of the biggest ones I can think of.
Great, thank you. No, that's super helpful. And again, during this time, if anybody in the audience has questions, feel free to put them in the chat and I'll read them out. I want to transition over to Mike. One additional question for you. So I wanted to ask about what your thoughts are on the patient communication piece of what you spoke about. I know that you touched on patient consent and how that is becoming increasingly important as more and more data become available. And so what are your thoughts on effective patient communication to help them understand the nature of that consent model as that's becoming more and more necessary?
Yeah, because what we want is informed consent, I think, right? So helping to make sure they understand it is important. So I think there's two pieces. One is, so how do I capture what we would call preferences, patient preferences for consent? What do they want to share with whom and so forth? In whatever vehicle you use for that, you need to be able to provide information about what the data is and what does it mean to say I share it or I don't. That way you're actually getting informed consent. There's a kind of a legal or legalese piece of that. State by state, there may be rules that you have to follow. There's a usability. And people like to do things on mobile apps today. There's nothing wrong with capturing preferences for what you want to share in a mobile app, as long as you can effectively provide the information that they can understand. So one is, as I capture what do I want to share and don't, make sure that there's a way to inform them. You have to also remember people are, in most cases, allowed to revoke consent and then give it again and revoke it. So it has to be able to remain current. The other thing is that I think what we found is the other part is the more you can show them their data, make sure that they can get access to or have either a summary form or some form. What data is it that you have on me? Which is a question that you get often when you go to ask patients for consent. It's like, well, what do you have? We're all familiar with patient portals in the EHR, the doctor kind of community. As we expand to what kind of data we want to deal with here, what does it mean to give patients access to that? They're not going to really decipher a stack of claims information all that well. So making sure that they know what data is being gathered is an important part of obtaining their consent.
Absolutely. Thank you. And I did have more questions for the Minot team, but I think we're out of time for our session. So perhaps I'll follow up with you all. But thank you all so much for your participation today. It's been super valuable knowledge that you've been able to pass on. So thank you.